I think, one of the things that's going to be that is so powerful about this project, and both, your role as a reviewer and your role now, is I think it's about application in a traditional practice. Like, I can go out there and be like, I have a practice with autistic and ADHD people, and this is the medical problems they have. But it's like, all right, well, that's nice. I don't have that practice. I think it's important to learn from how is this resource actually, like playing out in like the regular world, like in the traditional healthcare system.
Yes.
Because that's where the mass impact is. That's where most of the patients are. I'm curious, was this a pattern that you were already seeing in your patients?
I think there was somewhat of a pattern, maybe, but I think I notice it more now.
So when we first connected about this constellation of medical conditions, I kind of remembered you like be like, yeah, I kind of anyway. So like, was that a pattern that you think you had been seeing?
In hindsight, there's some people that come to mind. There's some patients that come to mind, and I'm like, oh my God, could that be for them too? Um, and I don't know if I could immediately connect it to, all the things. And this patient of mine, are they autistic too? Versus is, does it explain why they're not getting better on certain treatments? And I think pain was a big thing. Pain is a big barrier to patients that I see, whether it's treatment of obesity, diabetes, or just making any change to their lifestyle, but I'm in too much pain to do that.
Was this pattern, was this something you were already seeing?
I'd have to say personally, yes. I think all of us in medicine and in primary care, we tend to attract a certain audience at times, and perhaps in how I go about things, my audience has a certain number of folks for which there are a lot of interconnected and intertwined challenges, and so I was already, have been working with these patients for many years now, and learning from them, working with them and learning from them. And so this the presentation certainly validated everything that I've and my patients have been experiencing.
There's just so many people who don't know about this. We have patients who they've been struggling for decades. And the pattern wasn't matched. And I blame the healthcare system for that, because of the thwarting clinicians from being able to take in all this, and take in anything new.
Yeah.
What do you think of that?
I mean, what I tell the residents is like sometimes you will feel like you're kind of in a checkbox world, and we need to remember to look outside of the checkbox world and look at the person sitting in front of you and get them what they need. How do I get the care people need when it's so obvious and it's like low-hanging fruit, but insurance won't cover it, or insurance covers it and it's not available? It's like, if you want to help somebody, how about we start with the chronic conditions or prevention of the chronic conditions, or prevention of the exacerbators of the chronic conditions, but instead we're focused on the treatments. And you have to be this sick to get this treatment, but it makes no sense to wait until you get that sick.
System, right? The system thwarts everybody.
The healthcare system is so complex, even the people in it have trouble understanding it.
So like, you're seeing this and you're recognizing that everything's connected. And yet a lot of these patients, they've seen lots of clinicians.
Yeah.
What do you think gets in the way of professionals not making those connections?
Um, I think it's the dynamic between the provider and the patient. So the few patients that come to mind, I think there's something behavioral or mood related. And unfortunately, I think the patient is angry. What I've experienced as a barrier is a patient is angry and frustrated and fed up because they've been either objectively, obviously discriminated against, told off, told that they're not being taken seriously, and so they develop this defense layer. So, and that I think
in some cases can also be some of the pathology. Like I think fibromyalgia is another good example as a comorbid condition here. And then there's this overlap of some psychiatric diagnoses too. Severe depression, bipolar disorder, trauma. So I think that's been really hard because then it's hard to get in and really connect with a person. So behavioral dynamic, interpersonal dynamic, I think sometimes they're perceived as moody or dramatic, unfortunately. And a lot of these patients are women, not all. And this is where I would love to learn from you because I don't think I fully understand, and maybe I don't see the same population fully represented as you do too. Some people are in hiding, some people do not come to the doctor. But usually they're angry, frustrated, discriminated against, fed up.
The system is so broken. Why don't people get faxes? I have no idea. But, you know, little things like that, because to be honest, I feel like I think it goes back to what you're saying, just like all the things you have to keep track of, and then you're not feeling well. And then you have to go back and forth, and then you have to go through the phone tree. And I don't like the phone trees. It's just, it doesn't work. And
A lot of patients who have this constellation of intertwined conditions, they have a lot of, negative healthcare experiences. They feel that they have been invalidated, dismissed, that people didn't, they didn't get it, they didn't hear them. What do you think of that?
That's been a journey of discovery for myself in that I think as a physician, we hold ourselves to, I need to have the answer. And if I don't have the answer, that's going to be unacceptable to the patient. And working with these folks, that's not their expectation. They just want someone that will listen to them and work with them.
I think about neurodivergent nervous systems, and all neurodivergent folks are a very heterogeneous group, of course, but when I think about like even sensory processing, like the sensory systems that are either taking in more information than other people or less information than other people, an energy system, I think the neuroception system, the threat detection system, there are a lot of people who are extra sensitive to threat. And it's like acquired trauma physiology, that hypervigilance, that like looking. So if I'm someone who has hypersensitive neuroception and I enter a healthcare encounter, there's going to be something that someone's going to say or do that is, I'm more likely to experience as threat because of these cues from the environment, my lived experience, the vibe.
I think that underscores the importance of how we communicate. And you just look at the words on a page and you could communicate those in so many different ways, whereas the content's the same, but the way it's conveyed and the way it's received is so different. And we, I not only, I'm seeing patients, but I get to work in a training environment and spend a lot of time talking to our doctors that are training in family medicine of the importance of how they communicate and how they convey those messages. You're embedded in that individual's care, and they're going to partner with you. And that, yes, those tests were, we use the term negative a lot. The test came back negative, but yet that doesn't mean that there's not something going on. It's just that we haven't found it, or that the test won't show it. And trying to kind of communicate that is so important, especially when dealing with questions to which we don't have answers just yet.
I think that, energetically and cognitively, like that openness, like that constant, like that the metacognitive aspects of medical practice, where you're like thinking about how you're thinking and learning and moving through the world, and like, oh yeah, there's this thing that now I'm being presented with, and it wasn't like part of my thing, but I'm open to new things coming into it. Not everybody can do that, right? Metacognition and this like cognitive flexibility piece is a higher order brain function. And the system thwarts everybody, like the healthcare system. Like it doesn't just thwart patients, it thwarts us, like it thwarts clinicians. We're just like treading water trying to survive a lot of the time. We don't actually often have access to those higher level functions.
And then there's the time barrier. The very patients I'm thinking about, I asked for extra time and it goes so fast and it's not enough. And I even go over and it's still not enough.
You know, you're bringing up the barriers that happen, like the barriers to access while they're there. So
Yeah.
but there's so many barriers that even prevent them from getting there. So
Yeah.
you must pick up the phone to become to become a new, to make an appointment.
Yeah.
The executive functioning of like all those pieces too.
Yes.
And you mentioned trauma, all these people with healthcare trauma. It's like, well, I made the appointment, but I'm going to cancel it last minute because like my limbic system tells me that it's not safe to come back to this place.
The patients I do know who have a diagnosis of an autistic disorder or of some sort or something else going on with a neurodivergent diagnosis, because I think that's relevant to what we're talking about here, or people who aren't diagnosed or people who don't have the diagnosis. But I can think of a few people who probably either avoid care or even are discharged because of no-shows and things like that. And it's terrible. It shouldn't be.
I think systemic ableism is like so embedded in medical training and practice. All the people that when they don't come to appointments, it's like, oh, well, they no show, they don't care, they're not engaged in their health. But it's like, okay, whoa. It's maybe because of their disability that they don't know they have. You don't know they have, and they don't know they have.
The system is created a certain way. If you don't like it, then you can look for another job. I do know I have friends at other places that I won't name that are, yeah, as you described. They
Right,
you don't have time to think. It almost seems they don't really want you to. You just need to do these things this many times a day and move on to the next thing. And
you're a
I
cog.
yeah, but those docs aren't. You can see them not being happy. That's not what we went to school for.
These patients describe that in all of their years of failed healthcare interactions, they felt that they were not believed. And so they come in and they have the stories of, they were invalidated and dismissed and shut down. They were told, go lose weight. They were this, they were that, like just all of that. But these patients, especially these late identified neurodivergent adults, they have been invalidated and dismissed and shamed by so many people in their lives. And so they come in and doctor says, well, your tests are normal. And now it's this trauma response, which I think is a unique barrier to healthcare access and engagement that I certainly didn't get taught that in medical school. What do people say that when they after they've like seen that the map is like bigger than even the patterns, you can't unsee it. So has anything shifted at all about, you'd seen it already, but now that it's like, oh, this is a thing, has that impacted what, anything?
Interesting in some of the short answer is yes. The long answer is acknowledging, how things are interwoven. It's taking a look at our interventions, whether that's a prescription, a supplement, a modality that we're using, and recognizing not only the potential for good, for benefit, but also having to be cautious about, can this be harmful?
Like the relative contraindications. Like I didn't realize that in this particular subpopulation, these things that are evidence-based practice, like propranolol for POTS or something, I didn't realize that in this population, that is going to make this person worse.
Yes. Well, that's like muscle relaxers. I remember reading about muscle relaxers. I was like, reading it makes so much sense, but I have to admit, I've reflected a lot on who I've prescribed muscle relaxers to and who should or should not get them.
Yes. And it's really hard. Like, we trained in an era where it's like, well, don't prescribe opioids. And it's like, well, what do? You like muscle relaxant. It's like, and without like necessarily even recognizing like, what is pain? Really to actually think about, for some people, pain is their joints going out of alignment. It's mechanical. Yes. For some people, it's like they're cutting off their blood flow. Or like, people who, on surface appear to, be healthy, but they really have like really bad small fiber neuropathy. Just like all these things that I don't know, they weren't on my radar. They weren't on my radar until I experienced them personally. This is what's going on for a lot of people. So muscle relaxant, you just made them worse.
Yes, because I think I think a lot of our treatments serve, again, we have this huge spectrum of human, and it kind of serves this middle, and if you are in a system, which I am not, where you need to see someone every 15 minutes, you don't have time to think about all those other people on both sides. And that's, I think, where people don't get better, or they don't trust their doctor because they're not listening. But I'm not giving excuses to doctors, but when you're in a system that sees someone every 15 minutes, it's just a challenge. I did go through the guide. I haven't gone through it recently, but I found a lot of the things in the guide were things that aren't complicated as well. They're not complicated. And I think that's kind of what blew my mind. So
I don't know if you've, looked at the the clinician resource guide, and if there's anything in there that if you've used it, it's totally fine if not, but if you used it, I'd love to hear about that.
Yes. So answer, I guess, yes to all of those questions. Have looked through it, and using it as a reference when I'm meeting with a patient, and that's in the back of my mind. Going through things that we're discussing as far as symptoms they may be experiencing or signs they may exhibit, and that sense of, okay, what have we done, what have we tried, what else could we recommend. More recently, it was working with someone who is in experiences a lot of chronic pain as a result of hypermobility, and exploring low dose naltrexone.
Since talking to you, like especially like things like hypermobility, EDS, how do we manage that? I've reached out to our children's hospital, physical therapy, our adult, and luckily our physical therapy office right next to our office will take adolescents and help with joint stabilizing. And they gave me the name of the person who specializes in that. So it's been very helpful.
Looking at some of the medications that we've been using, or even supplements, and trying to fine tune those for minimizing the side effects, and maximizing the beneficial effects. And that's been an ongoing navigation process.
I love that you said that, like back in the day when we first started working on this, the idea of turning this pattern and stuff we were seeing into like a usable resource, it was really first and foremost about the latter. It was the idea of, wow, there are some standard medical interventions, medicines, supplements that actually make some of these other parts of the constellation worse. And holy cow, I don't know, like I didn't know that. I don't know if people know this. Like, so it was really about identifying those relative harms within the constellation.
And I think relative's a very good choice of word. I often have this discussion with folks that we're always looking at what are the risks and benefits of these interventions, and when there's the thought that the risk may be minimal, that doesn't mean zero, but that the potential benefit may be greater. I push that into the reasonable status. And again, getting back to the trying things, it's working and saying, okay, let's try this. we'll talk again next week, and then we'll find out if it was helpful or harmful or somewhere in between, and then let's look on the other part. So it's very much a team effort, and now it's becoming increasingly a community effort when there are, additional resources for all of us to, share victories and suggestions, and again, kind of try things with that ultimate goal of improving the situation.
Now that you have this framework, like you're a systems thinking pattern matcher, like that's how your brain works. So like now you have this it's not new, but like you have this thing that now you're matching, like as you go through the world.
Like even I have like this now, the hypermobility chart.
Yeah.
So I'm still learning, but I feel like I've come a long way since we've talked, and hopefully I'll keep going.
Yeah, we certainly have to acknowledge that we don't have all the answers, but we want to work collaboratively on addressing things that we're able to address.
Absolutely. Anything I didn't ask you about that you want to mention?
Oh, we've covered a lot of ground. I just, again, kind of reiterate that partnership that's so important with patients, and the navigating the journey together. We learn from our patients. A lot of the tools and techniques that I might be applying to folks, I'm getting them from others, and looking and listening and saying, okay, yes, you were on a support group, and this was the topic of conversation. Well, let's look at this a little bit more scientifically, and let's explore this treatment and find out if it might be a safe and effective modality that we can use. And a lot of times the answer is yes, and we decide to go forward and try something along those lines. But in the absence of those groups and those forums, we might not be moving forward.
I love that you said that, because I didn't tell you this part, but so Brain Club, so this program, this interviews with 3 or 4 primary care physicians talking about this project. This is part of where this is going to go. We have a weekly community education program called Brain Club, and every month has a big overarching theme, and then there's subtopics each week. So the theme for March is systems change from the ground up. And what you just said is exactly why this topic is in March Brain Club. It's next week's Brain Club. Because it's the idea, like we learned this from our patients. This really is this village here of learning and healing together. And it just so happens that there was evidence to support each piece of what the people brought us. But we wouldn't have been looking for it if they didn't bring it. And so really just co-creating, we had, more than 100 people in focus groups sharing what worked and what didn't work. And that's how we learned about the relative contraindications, relative harms, or like things that side effects we didn't know about. Anything else you'd like to say or share?
How do you talk to someone about all the things, and how do you even say that? It's so foreign to me. How do you kind of open up that door with a patient?
It's like this self-selected group of people whose needs were not met by the traditional healthcare system. They are, so it's and certainly not a homogenous group of people by any means, but amongst that group whose needs were not met, they were more likely to be autistic and or ADHD, and they were more likely to have this constellation. So a new patient comes in, and like I've done on my like new patient intake forms, I screen for all the things for all my new patients, and I'll send you what I use. It's very much like a simplified version of what we have up on our All the Things Project website. But so I'll say, I noticed that you had X, Y, Z, A, B, C. Did you know that there's actually a grouping or a cluster of intertwined medical conditions? And I usually, whether they're, if they're in person, I'm like, turning my laptop. If they're virtual, I'm share screen, and I show them a visual support. I think visual supports to sort of like anchor what you're talking about. I think most brains benefit from visual supports. Whether or not they are like dependent on visual supports or not to
Oh,
process
agreed.
something is
Totally.
different, right?
Yes.
Yeah. So the visual support I use, which is the one that's in the All the Things guide, is that, I don't know if you've seen like the rainbow braid.
Yeah.
That
You
has
showed
all the
that.
different systems. Yeah. So the majority of patients who come to All Brains Belong, they struggle with a grouping of medical conditions that involve something in the connective tissue bucket, something in the GI bucket, something in the sleep bucket, something in the, pain bucket. And like you see them, they're like, the mouth drops and their eyes are wide and you're like, and I'm like, oh, do you think that applies to you? Like, I don't know, like, they're like, that's me. Like 1,000% of the time, that's what they say. And I say, well, I think the healthcare system often interferes with clinicians having the opportunity to address multiple problems at the same time. But really what happens is that when we fragment out these different parts of this cluster, we miss the fact that there's like internal conflicting needs where some standard parts of this cluster make the other parts worse. And so like zooming way out, turns out that if we approach this through a lens of a big picture, we find the things that make your thing better without making the other parts of your cluster worse. Like in my practice, we do a lot of group medical appointments, we do a lot of like group learning and a lot of like visual supports and education and stuff. But I think like in a traditional practice, I might just like send them to the All the Things site, hey,
Okay.
check this out. And next time we can talk more about it and let me know if any of this resonates with you. Because there's all those patient tools on that site.
Thanks.
Yeah.
That's simple enough. I like it.
One of the things I think we still struggle with is that patients, I think, have often internalized the healthcare system narrative of like, well, what's this? What's my hypermobility contributing versus like, what's my fibromyalgia, or like, what's my mast cell dysfunction, or it's like, whoa, what would it look like to zoom out and say, like, we don't have to fragment your body parts. We could support your neuroimmune health in this way. Do you have any thoughts on that?
Well, I think that goes along the line of the specialization in many ways. And okay, you've got this body part, so you see this person. You've got that body part, and you see that person. And those people aren't always talking to each other, even though your body is.
Is there anything that you and the patients that you work with would like to give to doctors like me who are probably needing to learn more about, what is there anything universally helpful that we can do to break down a barrier and invite change?